turn it over to Dave Chokshi. Dave?
Okay, thank you so much. And I'm really delighted to be joining this important and I have to say very timely session to talk about our health workforce writ large. It's a privilege to be a small part of it, and I'm going to be focusing my presentation on our New York City Public Health Corps. Fundamentally, the Public Health Corps is the workforce that we should have had in place before COVID-19, before the pandemic was so devastating for New York City and of course for so many communities around the world. And so as we hopefully continue to emerge from the pandemic, this is an important and opportune moment for us to talk about the investments that are needed to place us on sounder footing going forward. We saw in our COVID response, throughout that COVID response, that we had to center our most affected communities. We developed what we called a hyperlocal approach, which was really about starting with our data, as you see on the left-hand panel in this slide, and figuring out where we needed to pay the most attention. Now, look, it won't be a surprise that many of the neighborhoods that saw the greatest burden of COVID-19 were the same neighborhoods that have demonstrated disinvestment and poor health outcomes far beyond COVID-19 and before the pandemic as well. But creating a hyperlocal response actually involved taking that data and going that additional next step to say that we needed to build upon the assets that were already in those communities, further invest in them, and in our role as a health department, ensure that we were listening with humility to what people on the ground in those neighborhoods were saying about what was needed to serve their residents, as well as supporting them in every way that we possibly could, but particularly through material resources. So I'll just give you an example. One neighborhood is the Tremont section of the Bronx, where we saw last summer that COVID-19 rates were about twice as high as other parts of the city. About 67% of the residents of Tremont are Latino, 25% identify as Black, and just 1% identify as white. 30% of the residents in the neighborhood live below the poverty line, and 22% do not have health insurance coverage. But again, we focused on an assets-based approach to communities. And so we tapped into the network of existing community health workers, faith leaders, care providers, nonprofits, particularly those community-based organizations who have been on the ground for years, if not decades, and have earned the trust of the residents whom they were serving. Those community partners helped us to pick the location of a testing center. They recommended a site that they knew that residents would know and feel comfortable with. And this actually involved moving some of our initial plans with respect to where we were planning to set up the testing site. And then the staff, many of whom were from the neighborhood that we were serving, helped with outreach by explaining testing and directing people to the site. And then other partners joined us so that it wasn't solely about testing, but also to connect people with resources once they tested positive. These resources included the local food pantries and food delivery, mental health services, and health insurance, all of which were vitally important during that period. All of our Tremont partners ensured that our efforts were focused on the needs of that community. They helped us to promote the testing services beyond the official channels that we were able to access. And most importantly, they lent credibility to the effort. We saw that this worked in neighborhoods like Tremont, but across New York City over the course of the pandemic. And particularly during our vaccination campaign, which brings me to the right-hand side of the panel here. These were some of the outreach teams that we stood up This is actually, you may not be able to tell, but that's actually me, my wife, and our baby daughter, who by chance had run into one of my department's neighborhood outreach teams as they were canvassing around vaccination. A great example of public health actually being boots on the ground and being present in a way that allows people to build trust over time. We did this across New York City, but as I mentioned, had a particular focus on the 33 most impacted neighborhoods, what we call the Task Force for Racial Inclusion and Equity Neighborhoods in New York City. I'll just move to the next slide here, which shows that although this is our approach during COVID, this is really something that extends far beyond COVID. We should think about this, the public health infrastructure that I'm describing, as fundamental as roads and bridges. And the short-term, medium-term, and long-term impacts are why. We saw during COVID how important this was to reduce gaps in vaccination rates. And we also have goals around helping public hospital patients in particular address barriers to health. But we have to move from those short-term outcomes to medium-term and long-term outcomes as well. And as I mentioned, this is the right time for us to be talking about those things as we try to foster and invest in a just recovery from COVID-19 toward those health equity goals that we all share purpose around. And so the Public Health Corps in New York City is what we consider at least a nation-leading investment in the public health workforce and that just recovery. This is with and for communities that have been disproportionately impacted. And so we're deploying community health workers in complementary spaces. The first is place-based community engagement via CHWs who are embedded in those community-based organizations that I mentioned, with support and capacity building from our health department. There's about 250 of those community health workers whom we've been able to invest in thus far. And then the complementary piece of it is healthcare system embedded community health workers, particularly through our public healthcare system, which is known as health and hospitals. They're embedded in outpatient clinics, including the clinic at Bellevue Hospital where I practice, pediatrics, behavioral health, as well as a particular focus on certain special populations, like people experiencing homelessness or people who are recently incarcerated. This shows a little bit more about how this model actually works in terms of the complementary approach between the healthcare system on the left-hand side, as well as the public health department on the right-hand side. Ultimately, this is fully integrated. The way that I think about it is that there are certain patients who will cross my threshold and make it into my clinic in the first place, but there are so many patients that we do not see, who never make it into the healthcare system in the first place, unless and until they're in extremis, in crisis. And that's where the public health department's role is fundamentally important to help with navigation, to help with connecting to both health services and social services, to uncover undiagnosed illness, particularly undiagnosed chronic illness, and to ensure that we marry our primary and secondary prevention approaches with the tertiary prevention that the healthcare system is responsible for. These are some of our preliminary outcomes. On the left-hand side, you can see some of our process measures in terms of what we've been able to stand up thus far. We were able to secure an initial $235 million in funding, a combination of city funding as well as grant funding, the majority of which is channeled to community-based or faith-based organizations, as well as New York City Health and Hospitals, the public safety net system, and federally qualified health centers. We have a total of about 500 community health workers hired and trained, and you can see some of the impact that they've had, particularly around the vaccination campaign in recent months. This is shown perhaps most strikingly in the right-hand panel of the screen, which shows how the gap between those focus neighborhoods, the Task Force on Racial Inclusion and Equity neighborhoods, the 33 places where I mentioned that were the hardest hit by COVID, as well as so many other health issues. And then the orange, which are all of the other neighborhoods in New York City. And you saw you're able to see between July of last year and January of this year, how we were able to significantly close that gap. This is a combination of the community outreach work itself, but also combined with our vaccine policies, which in New York City are among the most aggressive in the world in terms of adopting vaccine requirements and a vaccine pass for certain indoor settings. This just gives you a little bit more of a flavor of the work of the Public Health Corps. You can see what they're actually doing in terms of navigating people to vaccination sites. And just to wrap up here, I want to just redouble this call for what I think of as a time for massive investment in public health. We have a once-in-a-generation opportunity, I believe, to reimagine what public health can look like in the United States. The discussion today will focus on how this must be led by the people who are most affected and who know the communities that they serve, often, and the default should be because they're from them. And that's what's laid out in the left-hand panel here with respect to the vision for a public health corps, even beyond New York City. I'm grateful that there are some leaders, including Senator Kirsten Gillibrand, who's shown on the right-hand panel here, with whom we did a press conference just a few weeks ago, calling for this level of investment. Senator Gillibrand has announced a push for about a $55 billion national investment to be included in President Biden's budget request, which would replicate, the public health corps model across the country. My concluding comment is just that, this is the time for all of us to band together in terms of demonstrating the need for that investment, to have it be scaled appropriately, so that there is massive and durable investment in the community health workforce that we need, not just for the next pandemic, the next health crisis, but all of the slower moving disasters in between, whether it's chronic diseases, behavioral health issues, and of course, health equity. Thank you so much.
Thank you, Dave. I want to bring up 2 points that came to mind as you were talking. And the first is something that was said in the earlier panel today about the idea of not having a temporary scaffolding put in place during the pandemic. So as I understand it, these public health corps community health workers are not officially employees of the health department. So there are 2 questions. One, how do you sustain these as members of population health workforce? And 2, how do we reflect them in any of our enumeration efforts, which have historically been taken under the wings of the state health agencies, ASTO's profile survey, or NACHO's local health department survey? Because as this work plan came together, or this group came together to put together today's discussions and panels, there's the challenge of we don't get a good way to track the population health workforce. We're doing a fairly good job of tracking the public health official governmental workforce, but then that undermines the contribution and the value of the population health element of that workforce, which is also really important.
Yes, thank you so much. These are 2 very thoughtful questions. On the first, sustainment has to be, of course, foremost, in our minds when we're talking about leveraging the opportunity for investment that we have right now, but to ensure that it's not, a flash in the pan, as unfortunately we've seen after other health crises in the past. And, I think that the part of this that is up to us is to demonstrate return on investment, to demonstrate how important this workforce has been during COVID-19 in a way that shows value. I do think that public health is in the public eye, and understanding of the layperson in a way that is categorically different, even compared to health crises from before. And so what we're doing in New York City, for example, is we are standing this up, with some grant funding, including, federal funding that has been vitally important, for us to accomplish some of these early outcomes that I've mentioned, but then making the case for sustainable city investment so that we're not at the behest, of other government partners. But there is also a role, particularly for the federal government, to demonstrate that it's not just going to be for 1 year or 2 year, grant allocations, and really to be able to commit for a far longer time frame, to support sustainment of these types of initiatives. And then more briefly on the enumeration point, it's a challenge, a real challenge. But I think that the onus here is for us to acknowledge that public health needs to look different in many ways. And the community health workforce that I've described, that so many others are describing, is a part of public health. And so in the same way that our, epidemiologic systems have to adjust when, when case definitions adjust, we have to think about the right denominator and make sure that we're capturing that as much as possible.
Thank you, Dave.